in Belgium. Chris, Dr. Bazanga, I was talking to you a little bit before the podcast here about repairs because honestly, your clinic has become one of the clinics that most repair patients seek. Uh, the issue is that, you know, a lot of these repair patients have expectations that don't really match reality, right? Once you're a repair patient, once you've had your donor decimated, the top scarred, you have to scale back your expectations. It's never going to be like operating on a virgin scalp, and sometimes repairs take, it's a multi-step process, right? Because not only do you have to undo all of the stuff that the previous clinic or technicians did, but you also have to improve on that. So one session might be just removing grafts that are misaligned, and fixing a decimated donor, restocking the donor. Maybe you could talk a little bit more about, what does a repair entail? What have you been seeing lately in your clinic?
Lately, with the progress that we've made with FUE, unfortunately, there are also some setback because
Mm,
people are seeking either cheaper or people with no expertise that will just destroy completely the donor. Beside destroying the donor is all the scarring on a recipient area,
mm,
using bigger tools to make incisions, leading scarring, cobblestoning, ridges along the hairline that make almost any graft that can be placed there almost impossible to grow. So when patients come with a lot of plugs and you explain to them that it may take 3-4 sessions, and even after those 3-4 sessions they may require to go see a laser specialist to do some sort of laser resurfacing so that the skin can be smooth. They think that is we just blowing smoke into their face. They want everything to be done quickly and yesterday. And so when they are scarring and then you're removing, so you're creating another scarring layer. So it's important that patients understand that repair take time. Uh, we sometimes have to figure out angulation because when dealing with this repair and removing them, the angulation is nowhere normal. You can
mm,
have two follicles that are next to each other. One is looking south, one is looking west. And so you
yeah.
need try to remove them without creating a bigger hole
Yep.
that will lead to more scarring. And when you're doing on a hairline, it's unforgiven because now you're gonna leave the patient with scarring. And the temporal recession area is where I see the most butcher job because I think a lot of doctors just don't understand how the hair lay on a recession and the transition on a temple. And so you have people who have hair that are almost like antennas standing,
Yep.
and so then the choice of the type of hair that's being placed. uh, I see a lot of patients where they need the hairline work but the harvesting is done in the back. you know
Yeah.
Harvesting in the back is the easiest thing to do. So most doctor or most clinic will quickly go and harvest hair in the back. But when you really need a hairline work, there's no need to go take bigger follicles in the back. You can harvest hair from the side. That's where you have the surface hair, and then you can have a softer hairline and not this harsh hair that we see from the occipital area. So the challenge we're facing with the repair is decimated donor, decimated recipient, and patient. They go to the clinic that offer them 5,000-6,000 grafts, and then the donor is completely destroyed. They still uh, diffuse thinning, and they want a full head of hair with a hairline of Brad Pitt uh, or
Yeah,
George.
Jake Gyllenhaal's hairline, huh?
Exactly.
You know, the tricky thing, and this is what I've witnessed on the Hair Restoration Network, and I've seen a lot of patients who have had really bad hairlines, and a lot of the times they go to great clinics to repair them, but they're not satisfied because of two reasons. Either they didn't remove enough of the previously transplanted hair, or there's not enough actual, new transplanted hair to disguise it. So my question to you would be, what is your approach when someone comes to you with a completely, messed up hairline, botched sides and everything? Do you first want to remove those grafts and then at a second session, try to transplant? Because I feel like sometimes these patients are a little bit unreasonable and wanting everything all at once in one step. It's a lot. You got the donor that needs to be treated. You got, a lot of the times right here on this side, it's completely like closed off and angled weird, and it looks like, cat whiskers. So you got to remove those hairs. Then you have to actually treat the hair loss itself by adding more grafts. So you have all these different moving pieces. What do you prioritize first?
You know, when dealing with removal, what I tell patients is if we take too much of this hair out, we might creating more harm than good because we may creating more scarring. You end up like a Swiss cheese with a lot of scarring, and there will be no way you're gonna hide it. So we have to be cautious. So what I do, I usually remove one out of every two or three, just because I want to maximize the harvesting and also to minimize the scarring. So it's not always possible to remove everything at once and to rebuild at the same time, just because when you remove something, probably it was misangled. So you cannot come again in between those removal holes, making site to place new hair while you have all these holes that are communicated between them that may expose some of the graft outside, and the graft may not grow just because you have holes everywhere and some of those bulb may be exposed. So it's better to do a good removal session, and I usually do 2 3 removal session before rebuilding.
Hmm.
Most of the time patients are not happy because they want everything to be fixed, but it goes about educating them and explaining them the reasoning.
Yeah.
uh, it take one operation to mess you up, but it may take several operations to fix you. So it's important
Hmm.
that people start doing the due diligence, not just by seeing glamorous pictures that some people may post. Every day we fight with clinic that are using our patients on the advertising material.
Yeah.
So people need to start really looking at forums and see patients who are actually presenting their own case, because it's one thing for a clinic to show all the good results they have, and it's one thing another thing for a patient to show his own result, his own account with his own camera, and show all the different flaws of sometimes not glamorous pictures, but that's the reality of hair transplant.
Absolutely. I feel like you hit the nail on the head there. Cherry picking pictures and putting them on Instagram, Facebook, TikTok, all this stuff is completely different than when patients come on, for example, the Hair Restoration Network and share their actual genuine reviews, share their pictures. And a lot of the times, patients aren't taking pictures in the most favorable lighting scenarios. They may wet their hair, they may do different things to really show the public what it actually looks like. Whereas, like a lot of clinics, will take pictures of what looks like in a broom closet with no lighting, terrible lighting. The before picture is lit up very well, and then the after picture is like
It's in a
it's like
dark room, and
it's in a dark room, and it looks, you can't really see what the result actually is. And so I think it's so important to see actual reviews. And I have to say, on record, that you have probably the top 3 most reviews on the Hair Restoration Network. And I have to say that 99% of them are, they're knockouts. I mean, they're fantastic. um the results, the hairlines always look great. But at the same time, you also seem to get a lot of haters for some reason. It's it's fascinating, and I don't really know. I don't know why or how you would get haters. It's
if
fascinating to me.
you don't, you know, the good the good prophets say, in this life you face tribulations. So I'm a firm believer that you go through life, and not everybody will love you or will like you, but it's part of you know you stepping on some people's toes or some people ego. But it's part of life. Don't focus on that. Focus on the work that we do. I do get a
Absolutely.
lot of credit, but I have a team that some of them have been with me for the past 20 years. You know,
Oh yes.
most of my technician, as senior technician, they've been with me almost since the beginning. So we have spent countless time together. I've placed a lot of graft myself for a long time, so I know exactly, and I've taught them what they need to do and how they need to do it. Uh, so it's like an orchestra. Everybody need to know where to play the partition. So when we're facing with repair patient, you have, first of all, the psychological part of it, patient feeling down and maybe angry and not trusting. So you have to make sure that they understand the process. You have to explain the process. And sometime when you harvest those hair, some of those hair may be lost during the harvesting process, because they may have 4 or 5 grafts. You may harvest 3 because you don't want to take a bigger punch to remove the 5. So I've been asked question if you can replant those grafts. Yes, most of those grafts will replant them either in a donor or behind, uh, within the existing hair, depending on what we discuss with the patient. So I think there's some questions about that. Um, so I think repair patients, when starting hair transplant, I didn't know that I'm gonna end up doing a lot of repair. We have almost now 40% of our work are repair.
Yeah.
And I just came from London, where I was having consultation this weekend, and the amount of repair, the amount of devastation, is almost like it make you almost feeling like crying,
Yeah.
because it doesn't matter how many times we go to this meeting and explaining doctor what not to do, but it's just people just don't care. And I think a lot of patients, uh, they will take more time to choose their car when they want to
than a
purchase a
surgeon.
car than the surgeon. And I
Yeah.
think that people need to understand that this is your image, this is your face, and the donor is finite resources. So you cannot just deplete it and expect that things will turn around by themselves. It's very hard. It's heartbreaking sometimes. Sometimes we have to tell the patient that there's nothing we can do. If you have a patient who doesn't have anybody here, the donor is completely decimated, there's not much you can do.
Yeah, that's the most heartbreaking scenario. And I think people always associate Turkey with, hair mills and botched work and everything, but people don't realize that actually there's a great deal of even worse clinics in the US and the UK.
Now the
Um,
repair are coming from all over. I think, yes,
yeah,
the Turkish clinic, uh, they don't do service to what they do, but in Turkey you have great hair transplant doctors, and but they also suffering from the reputation that these clinic are doing to themselves. And so, we cannot just say bad hair transplant come from Turkey. That's not right.
absolutely not. Yeah.
That's not correct. There are bad hair transplant coming from all over the place. And it's getting worse and worse because now you have plastic surgeon who have zero clue about hair transplant. And for them, it's just a add-on
Moneymaker.
revenue. I can go do my BBLT there while somebody else is punching, and then uh, at the end it's just a profit. So that's what happened. The state of hair transplant today, it's scary. Uh, when someone is asking if we make a hole, is not gonna leave a scar, you know in surgery, when you make a hole that is less than 1 millimeter, usually it heal well without creating a scar. So the choice of also the punch that you're going to use to remove is gonna matter. If you make a
Mm.
hole that is a little bit bigger, then you have to suture it to make sure that you minimize. Some of you sometime have seen some of my repair where the patient end up being suture with a lot of suture around. The goal is just to compress the hole, so uh, to minimize the scarring.
So, I want to switch gears here just because I think there's been a lot of talk lately of oral minoxidil, and I'm gonna give a shout out to Kevin Mann of Hair Cafe. He made a video recently talking about oral minoxidil, and I had Dr. Sergio Vagno, one of the clinical researchers who did a one of the largest, actually the largest study looking at low dose oral minoxidil and its safety in patients. And I know that you've been not only prescribing low dose oral minoxidil, but you've also been taking low dose oral minoxidil yourself for quite some time. So I kind of wanted to just get your thoughts on it. He says it's not safe. There's been proof that it's not as safe as topical minoxidil, and the efficacy is almost the same, or I think he even claimed that the topical was better, but I'm not too sure about that. I
Who
think
say
that
that? Who say that?
this is Kevin Mann of Hair Cafe. He's a YouTuber, a big YouTube channel.
Yeah.
He
How many
he
patients does he treat per year?
none that I
Yeah.
can think
So
of.
yeah,
But in
you
your
know,
practice,
when
what do you
when
see?
you have, I would tell you, oral minoxidil and Sergio Vagno. The first time I heard Sergio Vagno talking about oral minoxidil, that when I myself get on oral minoxidil and I start
Mm,
prescribing. And then you have Sinclair in Australia who've been
Rodney.
using oral minoxidil for more than 10, 15 years on his patient, and now even using sublingual minoxidil because it has more efficacy. So, um, oral minoxidil, a lot of series, and people talk about side effect. You have a lot of people dying with paracetamol or Tylenol intoxication. Tylenol can mess up your liver,
Mm,
and but uh, so when looking at the medication, you have to look at the safety profile of it, and not just some side effects. Side effect. Every medication has side effect. If you take your car, you're not sure that you're not gonna make have an accident at the corner. So if we start really just looking at medication without looking at side effect, or just looking at side effect, then we should not take any medication, including Tylenol.
right. So in your practice, you have hundreds of patients a year. You prescribe
I've
probably you
prescribed
probably
more than 4,000 uh, uh, oral
minoxidil.
minoxidil,
Out
and
of out of
out
those
of that,
4,000.
I would say maybe 2-3% have a side effect that require them to stop, and the main
Mm,
side effect that require them to stop is palpitation.
mm,
Uh, they may feel like puffiness around the eyes, or
mm.
some swelling around the feet and all that. But
Edema.
that's the edema, pedal
Hmm.
edema, and those are were the main side effect. Now I came across, we have one or two patients I think been reported to have pericardial effusion uh, with oral minoxidil, but overall there are some studies that show that real the change in the blood pressure and everything is very limited.
Mm,
So when talking about topical minoxidil, topical minoxidil need to be transformed by the sulfonyl transferase on a scalp for it to be efficient. And 30 to 50% of the population lack the enzyme, the sulfonyl transferase. So, but the sulfonyl transferase is in the liver. So that's
mm.
why oral minoxidil, everybody has a liver. So that's
Yeah.
why oral minoxidil can be transformed, and that's why you have all the systemic effect that you can have a lot of hair growth, unwanted hair, especially in female patient, that you don't have necessarily when you're taking the topical minoxidil. A lot of people may take topical minoxidil and it's not going to be effective as oral minoxidil. Period.
Yeah. What would you say? Because I took topical minoxidil for many, many years. I want to say probably close to 10 years at least. Um, and for me, the efficacy was, I mean, I wasn't sure if it was even effective. I was taking it just because I was like, well, it might be doing something, but there was no comparison to the oral minoxidil. I mean, it's night and day difference for me personally. I can tell not only is my hair growing faster, it feels thicker, it feels better quality. I don't shed as much, um, and yeah, I have my body hair grows faster. That's, I guess, not a positive, but I haven't had any edema, no tachycardia, no heart palpitations, nothing like that. It's been very, very, very good for me. Um, so yeah, I was just wondering what the percentage is in your practice, because I know you've been prescribing it now for a few years. I think aside from Dr. Vanyo and Dr. Munoz and Dr. Rodney Sinclair in Australia, I feel like you're the fourth guy in line who started talking about oral minoxidil.
Myself, I use Rogaine for almost 20 years. All my younger brothers are bald. I use oral minoxidil, but I was still losing hair. I tried Finasteride for a couple years, but then once I started reaching the 50s, I didn't want to take Finasteride anymore, so I switched to oral minoxidil, and I was surprised how much hair I gained
Hmm.
I was on finasteride. So when I switched, I gained more hair on my head myself. This is my personal experience. Than with both finasteride and topical minoxidil combined. So
Wow.
I started looking into it seriously, and that's my drug of choice for most patients. Just because uh, a lot of patients, when they come, they don't want finasteride.
Hmm.
In US maybe people take it easily, but here in Europe, especially in France, there were a TV show where they show that it's a poison. People should not take it. So
Yeah.
it resonated with a lot of people. So it's almost a lost battle in a consultation to try to prescribe um, or finasteride. So then trying to look for alternative, start giving people oral minoxidil. And a lot of patients I have, a lot of patients, even after the transplant, they say the overall hair you transplant in the front, but even the crown get better and all that. So for me, it's the better drug of choice. Now, even if you listen to Sergio Vagno, the first choice of hair loss medication is now dutasteride, and the
Yeah.
second oral dutasteride, and the second
Yeah.
choice is oral
Oral
minoxidil.
minoxidil.
Finasteride come third.
Yeah.
So for younger patients, I usually give them dutasteride and oral minoxidil as a first choice. For older patients, because of erectile dysfunction or people who have past medical history or of depression and stuff like that, I try not to give them any DHT blockers. Then I give them oral minoxidil.
Yeah. And I feel like so like Dr. Vanyo's go-to stack is number one, oral dutasteride, 0.5 milligrams daily, 5 milligrams of oral minoxidil,
Minoxidil.
and then dutasteride with mesotherapy.
Yeah.
Those three things, that's like his main go-to. If you
I
do
do a
that,
lot of mesotherapy with dutasteride, and it's amazing the change that we see.
so talk about a little bit. I mean, there's not a lot of people um doing I don't actually I have to say I don't think there's even one surgeon that I know of in the US doing dutasteride with mesotherapy that I know of. I This seems to be something very European, um, and I have no idea why more people aren't exploring it. But talk a little bit about the dutasteride with mesotherapy. What is it? How often do patients need to get the treatment done? And how effective is it in your practice?
So mesotherapy, by definition, was something that was invented by a French doctor. So if it's more a European thing, it's probably because it originated
Mm,
from Europe, where they starting injecting vitamin into the scalp, into the skin, and they say they see the benefit of it. Drug manufacturer in probably in US were not keen into mesotherapy because it's just about money, probably. So they never push mesotherapy in US for skincare or for anything. So
mm,
probably that's why the difference of approach between Europe and US. But mesotherapy is very popular in Latin America, South America, and Asia, where
mm,
they use it a lot. So when uh, looking for solution for hair loss, again, Sergio Vagno and some of the doctors in Spain, because they were using a lot of mesotherapy already with vitamins, with a lot of things into the scalp. So they started looking for a way to get dutasteride compounded in a solution so that can be injected into the scalp. You can inject it we usually do every 8 weeks because
mm.
it has a long half life. Um, Dutasteride can be painful because of the mix. So you have to actually add a little bit
Tumescent.
local anesthesia into
Mm.
it so it doesn't burn. But it's a safe procedure. People can come and do it. I've seen a lot of improvement, especially with my female patient who have telogen effluvium, chronic telogen effluvium that we put on dutasteride. They see immediately the shedding is minimized, and so it's very effective. You know, I know US people were pushing for exosome and everything, but it's
Yeah.
the same principle as mesotherapy, but they just call it exosome because it's other signaling molecule. But dutasteride in mesotherapy is effective.
And dutasteride is a proven. I mean, it's
It's a
it's
proven drug.
it's a proven drug. It's by far the strongest medication we have on the market. No questions asked. It's better than finasteride. No questions asked. It's a stronger treatment. You know, a lot of people feel like they're worried that dutasteride isn't as safe as finasteride. You know, I don't know. I feel like they're pretty close, especially if you're using it through mesotherapy. Um, have you had any patients experience any side effects with the dutasteride and mesotherapy?
I haven't, but there are accounts in literature of people having swelling immediately after the injection of dutasteride or pain. So probably those who have pain is because the dutasteride was not mixed with local anesthetic, and I think that could be the reason why they have pain and also the edema. Um Dutasteride is being recognized by the Korean FDA as an indication for hair loss, while the US FDA didn't approve it for hair loss. So when using for hair loss is off label, but I think you also have to look at all the dynamic with drug manufacturer lobbying and all that. So Merck
Oh,
has made
without a doubt.
a lot of money with finasteride, so it was not in the best interest for them to have dutasteride accepted. So regardless of all that, is effective in a practice, in a daily practice. We're seeing improvement. It's not just one case, two cases. It's not just few case report. Is case all over the world where people use it. The doctor will use it. They see as efficient, and when combined with oral minoxidil, it's even more efficient. So I think people need to start having an open mind when it comes to treatment of hair loss. You know, I always say there's more to the DHT theory. It's not all about DHT when it comes to hair loss. People lose hair because of inflammation. People lose hair
Mhm.
because of environmental factors. So there's multi um, factors that we need to consider, and so inflammation play a role. So there are more and more studies showing that you can really combine different type of medication for you to get a um, better treatment. You know.
Yeah. Yeah, I feel like, and an important thing that Dr. Vanyo said about oral minoxidil is that it treats many forms of alopecia. So the most common and probably what most people watching right now have genetic alopecia, androgenic alopecia. But there's also the telogen effluvium, which occurs after a hair transplant. There's uh, scarring alopecia. There's alopecia areata. There's all these different forms of alopecia that affect people that this drug actually treats. Whereas dutasteride, finasteride treat mainly genetic alopecia because it stops DHT. And I think you hit the nail on the head there about US FDA not approving dutasteride. Well, number one, I feel like finasteride here, Propecia and Merck have gotten a lot of lawsuits, and so And I think they initially wanted to make Propecia like Rogaine, something that would eventually be over the
Because
counter,
they, mhm.
but unfortunately that didn't happen. So it's not, it didn't really make any sense for them to market Dutasteride, which is a
But
stronger
again,
drug.
drugs. Exactly.
Yeah, it just didn't make any financial sense. So that's why I think it's not FDA approved. I don't think that it's because it's completely unsafe. Do I think that people get more side effects than finasteride? Sure. I mean, I think it could be a little bit more than finasteride, but I think that if you take finasteride and you don't have side effects, you probably aren't going to get side effects on
Side effect of
dutasteride.
the right. Hmm. Yeah.
But there's always a threshold, right? So somebody might get side effects using it daily, but maybe they don't get side effects using it 3 times a week. So I think everybody just has to figure out what their threshold is,
In
what suits their body the most. Some people, get side effects with 5 milligrams of oral minoxidil. Maybe they need to drop it down to 2.5 milligrams. Maybe with 2.5 they don't get side effects. Something is always better than nothing, and I think that that's important for people to kind of work with their doctors and see what treatment's best for them. Looks like we have a ton of questions. I'm sorry, guys. I've been having a good conversation here with Chris. But let's get to some of these questions because I know people are eager to talk to you. Go ahead. E- Oh yeah, he answered that. Yeah, that can definitely be done. What's the next question? That's a good question. So, what's the percentage? Some doctors, like I believe Dr. Zarev in Bulgaria, is doing 50% of the donor. He's harvesting. Some
yeah.
clinics say
You know,
35%. What do you
y-
feel?
when you harvesting, when you're looking at the donor, first of all, not everybody has the same type of donor. You have patients who have what we call simple donor. Most of the hair are one, two, very rarely three hairs. Those patients, if you even take 20% of the donor will look bad.
Hmm.
Then you have those who've been blessed with very high density, big groupings. Those you can take 60, 70% and you look like nothing happened. So we cannot make a single rule for everybody because everybody is different. We don't talk a lot about donor assessment. People, when I ask people to come for consultation, they sometimes they don't want to come for consultation because they think that is a waste of time. No, it's not a waste of time. It allow us to really accurately measure your donor, see exactly how many we can take, and make plan. Now, if you take 50% of a donor on a patient who's 25 or below 35 with a strong family history of hair loss, you may end up 10, 15 years down the line with something that do not look natural at all.
Hmm.
Because if you take 50, 60%, you are going outside of the traditional safe zone. You harvesting hair that are DHT sensitive. This hair probably in the course of the time they will be lost
Hmm.
because they were taken from an area where they're not supposed to be taken from. So people should not focus on what the percentage. People should focus on what type of donor do I have, and then out of that donor, how many can I take safely? I
Yeah.
don't know if it makes sense.
No, that makes sense. And I've always said, it's always an individual basis, right? Some individuals you might be able to get more donor. Some individuals you may have less, and it all depends on the specific person. And I know you personally have gotten a lot of flack for making patients go in person for a consultation, but I think that is so crucial, so important, because especially if you're looking at the planning, you're looking at how many grafts can I actually get. I know a lot of people have gone to clinics to say, oh, it's going to be 3,000 grafts, and then they go in there and they're like, wow, your pictures didn't paint the accurate story, and you actually need a lot more, or maybe you need less. And so patients get upset about that. So it's important to go in person and to actually know exactly, all right, this is what my donor, and even to know that your donor is suitable for transplantation, because not everybody is a candidate, and we got to be honest with that.
Is donor, but is recipient. There are new entities that have been described that are called FAPD. It's more scarring alopecia in the pattern distribution that can mimic uh, um, androgenetic alopecia. So, patient with FAPD, lingering FAPD, if they undergo hair transplant, they're probably not going to have growth, or they'll have very poor growth. So we started just understanding that some of the failed hair transplant we had in the past is probably because patient had some sort of scarring alopecia that just started, but because there were no tools or nobody was teaching about it, people were undergoing hair transplant and then end up with failed hair transplant.
Hmm.
So it's important to check, to have a thorough examination of your donor, but also your recipient, to rule out scar, scarring alopecia. How you rule out scarring alopecia? If you're not sure, you send to a dermatologist or you biopsy. If you have scarring alopecia, probably hair transplant is not going to be a good solution. But imagine if you have flown all across the world to some clinic, and you are the patient that they book, they have a revenue on that day, and then you have scarring alopecia. So sometimes they may wrestle with the decision: do I operate? Do I not operate? But I think it's best to see the patient so you don't base your decision on a surgery day based on a financial mean, because you have a staff that you have to pay, you have
Yeah.
bills that you have to pay, and you don't want to take advantage of this patient who have flown from across the world because he didn't have consultation. Me, I'm lucky. I have trained doctors all over the place, so I can sometimes just ask a patient in Australia. I ask my patient, go see Dr. Bevin. Dr. Bevin worked with me for 4 years. He's now a dermatologist in Melbourne. He worked with Sinclair. So he sees most of my patients there, and he make the recommendation and he send me the report. So it's good to have some friend all over the world that can see your patient without taking them and do the surgery. So, but it's important to have your donor and your recipient checked by a qualified hair transplant surgeon.
Yeah, absolutely. And yeah, you have to be one of the most doctors that train. You got the ECAMS training. You're heavily involved in training, and I wish more doctors were like you, doing, training the new generation. Dr. Costas is definitely a doctor to look out for. Hopefully, we can get him on the podcast soon. Let's go to the next question. So this is one of the questions that people ask all the time. What percentage should I be at this month? Uh, Before, and there's charts that you can find online that say 6 months should be 50%. 7 months
That's
should
a
be
rough,
70.
that's a rough, that's a rough estimate. 6 months, you should have 50%. But now we know that there are few things that delay growth, especially the manipulation of the hair follicles during the procedure. So, uh, if especially with FUE, if a clinic is placing mainly with forceps, they tend to manipulate more the graft than if you place with implanter. So, what we see generally when FUE is being placed using implanter, different type of implanter in the market, you have early growth, and so you can see those growth that we're seeing, that I've been having, with 50% at 3 4 months, and I'm sure it's a combination of how you handle the graft, uh, post-op care, or minoxidil all together probably give you a better yield than just if the grapher manipulate any kind of way, and regardless, because people are in a rush to finish, or they have 10 patients and then they have to vacate the place. So again, when we're talking about this procedure, we cannot generalize because everybody has a different protocol, and so what is good in one clinic is not good in another clinic, and so we cannot just compare apple to apples. It's very different things happening. You'll be shocked.
Yeah, it's always funny when people give these like blanket statements about, how much growth you should have, because I feel like everybody's different. Although I have to say that the majority of your patients in particular seem to grow pretty quick. And you mentioned something about, the handling of the grafts, being on oral minoxidil. I think those play a crucial part in how fast the hair grows. But that doesn't necessarily mean, like, if you're not on oral minoxidil, that doesn't mean that the hair isn't going to grow. It just may mean that it may not grow as quick as someone who's on it. And obviously, if someone mishandled a graft, the hair may not grow, just period. And if it does grow, maybe it grows super late. So all of those things definitely play a factor. I also wanted to shout out to Mr. Rolandes. I saw him in the chat a little bit earlier. Um, he's a YouTuber. He hasn't made a video in a while, but just wanted to give him a shout out. Let's get to the next
You say
question.
they don't hear the questions, so if you can up the volume for the question.
Oh, okay. Sorry about that. We'll try to speak a little bit louder. What's the next question, Jerry?
Okay. Is Dr. Bisanga willing to use Verteporfin?
So I talked to Dr. Bazanga and Dr. Umar and Dr. Rasman at the LA Hair Restoration Conference. And I haven't presented Dr. Bazanga with any of the actual medical literature. Hope, you know, I feel like Dr. Bazanga is a very pragmatic person and a very see it to believe it type of person. So I don't know if he actually believes it, but I don't know. Maybe I'm talking out of context here. But Chris, what do you think? I'll send you the Stanford article that was looking at verteporfin, and I know that you had a lot of thoughts on ACell, and and you think that it may be another ACell situation, which I think is fair, absolutely fair.
They're asking you to repeat the question, to read the question again, because they cannot hear the person reading the questions. But for the Verteporfin, um, I'm willing to try if there is some really evidence. Uh, I've been in the game for long. I've seen trends coming and going, and I have seen people talking about ACell. That was the game changer, and then we saw the damage that ACell created in some of the patients that were left with a strip scar, the wound open, and some powders of ACell in it, to thinking that there will
Hmm.
be regeneration. And so and then we saw the exosome movement in the meeting, everybody was swearing by exosome that would be, but you know, it seems like every year, every 2 years, there is something that is being presented, but at the end, it's very little. And those who advocated for it will disappear as they started. So
Mhm.
this is not to blame people who are involved in the research, but I like to see more evidence. Today we have good equipment that can match uh, hair to hair growth, um, so we can know exactly this was the area that was they used the product. This is the area that they didn't use the product. This is the type of punch that was used, and this is what we have. So we need, if you show me a picture of a donor that you say it's a regrowth, how do I know if there were no transection in that area and is a transected hair that is growing?
Mm.
So all these questions need to be answered and not just brushed on the side. Uh, so I know people are excited about things, but as I say, I'm down to earth. I don't want to take people's hard-earned money with things that are not proven. So that's the only reason that I'm reluctant to use everything that is a trend.
But to be devil's advocate, um, you are the exact type of person that should be trying this because you're not going to sugarcoat anything. You're not going to uh, do anything misleading. You're going to give us the absolute truth. And if it's a bust, which I have to say, and for the people who are out there who don't remember ACell, or because ACell used to be the rage about 10 years ago. So what ACell was, it was an FDA approved drug made out of pig's bladder that showed to help with healing. And many people were saying very similar things, and I have to say, Chris, you're dead on with it. A lot of people were saying that A cell was regrowing hair in the donor, and it was creating no scars, and that very similar to verteporfin. You were absolutely dead on with that. And what people found was that it didn't really do anything. And you mentioned that some surgeons were creating a strip and just packing a cell in there and not sewing it up, which obviously is a terrible, terrible, terrible thing to do. But in my opinion, and this is just my opinion, I think that whenever something like that comes on the market, it's good to try, get multiple surgeons doing multiple trials, and get the truth. If it's a bust, then it's a bust. Then at least we know, hey, we tried it, it didn't really do anything, we can move on. But I think it's always good to at least try it. And someone like you, who's pragmatic, very scientific, is the ideal
Listen,
surgeon.
Melvin, I will tell you something that maybe a lot of people don't know. I'm working with a company. They are based in Poland. It's
Mm.
Tricolab. We're working on a way that we can do what we call a hair-to-hair match before and after the surgery. So basically, it's a virtual tattoo on an area. So when you come back, the artificial intelligence will recognize the pattern of the follicle around the same area. So then when you remove the follicle, you can exactly come and see the same area. And so you can measure and say, okay, in this area, we removed 50 grafts, and we can say that we have a regrowth of X many percentage. Today, there are very few technology that will accurately say that, okay, we have a regrowth, because everybody can say, yeah, I have a regrowth. So I'm willing to work with the company that is doing Verteporfin Uh, but we need technology also to measure. We need tool to measure. Things has to be measured and be reproducible for them to be used on a larger scale and say, yes, it's working.
Mm,
You know, that's how science work. You can't
yeah.
just do it in your own and say it's working. You know, people should be able to reproduce it and come to the same conclusion.
Mm,
So
dead
I'm not
on.
just reluctant for being reluctant. I'm looking for tools, because if I take a clear picture and then the lighting changes and then I say, yeah, there is a hair there and all that, those are very subjective uh, assessment. We need something that really is irrefutable. I
Mm,
spent a great deal of time assessing donor, checking, measuring density, hair count, percentage of miniaturization. There are very few doctors that look even at the miniaturization, uh, because all that has an impact on the growth. So when assessing a donor area for growth or a recipient area for growth, I think we are working to get tools that everybody can use and every doctor can use and say, okay, this is efficient, this is not efficient. So I don't have any problem flying to Jordan and see Dr. Begudi and discussing his protocol and see how it's working. So that's not a problem. But we need tool to reproduce and do some evidence-based medicine.
I agree 100%. I think that's exactly precisely why so many people are urging you to join. And it's very interesting what you mentioned about the company in Poland, and I think that you're dead on with it has to be reproduced, because what good is it if one person, one surgeon in one location did it one time and it worked? It doesn't benefit anybody, right? It has to be standardized. It has to be something that can be done by multiple people all around the world and treat multiple patients, because that's really what's going to make it effective, and that's what we're all looking for. So making it streamlined is critical. I mean, I'm excited, but at the same time, I can completely see your point of view, and I think that it's being pragmatic is important. A lot of the times, people they, hair loss is something that affects people deeply, and they want to get the situation fixed. And when something comes along that may potentially, cure them, then they can get excited and throw caution to the wind and not think about anything else. So it's very important to have someone like you keep us grounded and say, hey, look, these are the things that we need that are necessary to move forward and for it to really be something that's effective. So I have to thank you for that, Chris, for that insight. And if you can please send me the information about that Polish company, I'd love to write an article about it and post it on the Hair Restoration Network for more people to know about it. Let's go to the next question.
Next question. What if your pattern of growth is good at 7 months, but density is still not good?
What if your pattern of growth is good at 7 months, but the density is still not good? Um, mhm.
What make density? Because people, when they talk about density, we really have to to break down what density is. Um, Hair transplant, we know it's an illusion of coverage. So you have to break the density based on the surface that you cover and the type of hair that you place. So, for example, if I take a patient and I implanted 40 follicular units per square centimeter, that's considered high. But if most of the hair that I'm implanting there are 1 and 2, the appearance of thickness is not going to be the same if for the same density I implant hair of 3s and 4.
Hmm.
So sometimes people complain that it doesn't look full. But if you only have 1 and 2 hairs, it's not going to look full. And sometimes I refuse patients because of that. With
Hmm.
7, you only have 1 and 2 hairs, you never look full.
Yeah.
It doesn't matter how many hair we place there, you're not gonna look fuller. So it's important that people start understanding what is in your density.
Hmm.
We usually transplant half of the original density. So let's say your average density in your donor is 60, 65 follicular unit per square centimeter. It's not going to make sense for you to have a transplant with 50 follicular unit. So if you have a density of 60, if you give you 50% of 50, it's 30.
Yeah.
So you may not be happy with the 30, but that's what you can have based on your total donor reserve.
Hmm.
So everybody wants these higher numbers, but you really have to look at individual donor area and then assess them and they educate them so people don't have false hope and they don't just say, oh, I have patients are coming, they had surgery on another doctor, they're not happy, they're ready to bark and create problem. But then when you look at them, you say, okay, you had 3,000 grafts, but it was spread over 120 square centimeter.
Yeah.
How many follicular unit you want to have per square centimeter? It's 30, and we counting 30. So you have 100% growth.
Yeah. It's just not what they wanted.
Yeah.
Yeah.
So
That.
you have to break the density based on the surface, based on what is included in that density. And, if you have a node 7 with a 300 square centimeter of balding area, if you have 300 square centimeter of balding area, if we give you an average of 35 follicular unit, it's 10,500 grafts that you need. So if you have 7,000 grafts, it may sound like you had a lot, 7,000, but actually it's not a lot, because if you spread that 7,000 over 300 square centimeter, is only roughly less than 25 follicular unit per square centimeter.
Hmm. And you're not going to have enough. And I think that's a critical point, because a lot of people will say, well, what's the best thing to do then? Is it to spread the hair out and give you less density, or is it better to just focus on one area and give you the number of grafts per square centimeter that you want in this one particular area, but you're going to have a bald spot. The crown's going to be bald, wide open. What do you prefer to do in that situation?
I'm an advocate of finishing one area before moving to another area.
Mm.
I don't like spreading, because it just creates too many issues with the patient, because crown take a lot of graft. If you start spreading in the crown, patient will come and complain that they didn't get any result, but actually they don't understand the math behind it. So I really like to finish an area before moving to another area. And then when we move to another area, especially the crown, we use body hair. Body hair may be coarser, but most of the time is one hair.
Hmm.
So I'll just ask for patients who are node 5, 6, and 7 to be patient, or to invest in getting 15, 14,000 graph for them to be happy. So it's a matter of numbers and surface.
Yeah. It's all supply
And
and
demand.
demand. Yeah, it's what it all breaks down to. Um, let's go to the next question here. We have so many. I think we've missed a bunch, but what's the next question?
Can you repeat the question so we can hear them?
Available donor during detailed assessment. Is it using a robot? What does this take on the robot counting and the report generated?
Can you repeat it, Jay? Let me hear it again.
Can you repeat the question?
How does Dr. Bisanga count the available donor
How
during
does
the detailed assessment?
hmm,
Oh,
okay?
the
How does
question is,
Doctor?
how does Dr. Bisanga count the available donor during detailed assessment? Is he using robot? What is the take on the robot counting and the report generated from it? First of all, the robot is me. So I have two sets. If you come to my consultation, I have two sets. We have equipment that have artificial intelligence that um, count, but I also count manually all the hair. I was trained to count hair manually for a long time, so I usually trust what I count. So I've been even doing when this company come, I usually count and then they count and then we see what the difference and what the relative error between what I count and what they count. So we always have a manual count and the assessment by the machine.
Mm. Yeah, I mean, you guys, Dr. Bazanga has been doing this for 20 plus years. There was no machines back then. It was all you had to you had to count, using a pen and pad. So yeah, that's I'm interested to know if one day that will be. I know there's some doctors, like I think Dr. Lorenzo has a system where he will, look at your donor capacity, look at how many grafts can be extracted, and have like a very systematic approach to surgery. I don't know if it works or not, but do you think anything like that will be developed in the future that will be streamlined across?
Yeah, you see, the problem with this technology that I've seen some of this technology, and where the patient to be told that, yeah, but we took X amount of number because based on the calculation, your donor should look okay. But then the patient is unhappy because the donor doesn't look okay. Why? Because maybe when they calculate this thing, they don't say how many threes, how many fours, how many. So they end up taking a lot of those threes and leaving the donor with a lot of singles and one hair that basically the patient is not going to need. So that's why when you assess donor, you don't just assess the number of what you can take out of the donor. You have to see what type of hair you're taking.
Hmm.
When I see a count of graft count, in most of the scalp, in a donor, 10 to 15% of our hair are singles. Very rarely you find someone who's a good candidate for hair transplant who will have 30% of singles. So when I see a patient posting his story, say, oh, he has 6,000 graft and he has 2,000 singles, I know that it's not normal to get 6,000 graft and get 2,000 singles. Close to
Hmm.
25, more than 25%. It means that they've been just either breaking or transecting hair and all that. So when reading the report, I can exactly assess and see what went wrong or that things do not adding up because I've analyzed a lot of donor area. I know the average number of hair, single hair, double hair, triple hair, four hair in a single donor. Dr. Rassman was the first one, and Dr. Bernstein who really work on this already in end of the 90s. Uh, but nowadays we have tools and all that even can get us more accurate count of all this data that most doctors don't even bother taking.
Yeah.
So it's important to know because if you come for a consultation, Melvin, and I see that you have 30% of your donor is single hair, I would say you're not a good candidate. you're borderline candidate, no candidate for hair transplant. So
Yeah.
the number of singles compared to the number of hair that you have should be also in line and make sense. You can't have
Mm.
6, 7,000 grafts and have 3,000 singles.
Singles.
You
Yeah.
breaking you breaking the graft, you transecting the graft, call it whatever you want, but so it's important to have this assessment. When I do the assessment before the surgery, I have all those pictures. So when going into the surgery, I know that this patient has a lot of trees. So if I'm punching and I'm not getting all these trees, then I have to stop and start reassessing myself. Am I transecting or not? Is the punch size appropriate or not? That's how you adjust and fine tune your surgery based on the patient data that you have prior in a consultation. What you had in a consultation should match what you're having in the surgery.
Mm. Yeah. Um, I, I want to ask you, because I know we've taken a lot of your time here, but I want to ask you one question a lot of people always ask me, and that's about concealers after a hair transplant. So a lot of people out there, and especially a lot of my viewers, because I used to make a lot of videos about Topic and Derm Match and stuff like that. How soon after a hair transplant would you recommend somebody using Topic or Derm Match safely?
It depends again. Um, After hair transplant, the skin is sensitive. So anything that you can apply there can create a dermatitis, a contact dermatitis. And that will be the worst thing that you want to have when your hair are growing. So I usually tell patients to wait 4 or 5 months after the surgery to use anything. If they have to use it, they use it and they wash it. But what I've seen patients, they'll say they wash it. When they come for assessment, you see all the fibers when looking at them on a trichoscope. So for me, it's about protecting the investment that you put into the surgery.
Yeah. I and but
I've
do
done
you
a patient, I will tell you a story, true story. I've done a patient 2 weeks after surgery, 3 weeks, he applying uh, topic like crazy, and he didn't wash them, and then the topic cake up, and so he didn't have any growth. So he came,
Mm.
and then I told him, okay, this time you're not going to apply topic. And we did the patch test, and 100% grew.
Mm.
He
Wow.
got, and I biopsy the area that he had the topic, crust of topic. He had a lot of inflammation underneath. So for me, I always say to the patient, it's a matter of choice. Either you protect your investment or you're taking a risk.
Yeah, I think that the biggest thing with people that use Topic and these concealers is that uh it's almost like the people that use the hair systems, right? It's because people see them and they're terrified. They don't want to go back to work, and people be like, "What happened to all your hair?" So it's a bit of a shocker to them. But I think what you said about the inflammation is very key and crucial, because I have to say that the times that I used Topic or Dermatch and I didn't wash it out for maybe more than a day or two, I got dermatitis. I got really bad rash on my hairline, and I could
Mhm.
just feel the inflammation. And especially with Dermatch, it is so important you probably got to wash your hair maybe 2 or 3 times to really get it all out, because that stuff, not only is it waterproof, but even when you use shampoo, it doesn't really get out that well. And some people will just use like a conditioner or something. It's not coming out like that. No way. Especially if you use hairspray or stuff like that,
Yeah,
it's
exactly.
is not coming out. So just be mindful, if you are going to use it, you have to really wash your hair out really, really, really well. And if you don't have to use it, like if you can get away with wearing a hat or something, that would be my suggestion, because yeah, it can definitely cause inflammation, and that can be detrimental to the growth. Um, we've been over an hour, Chris. I'm sorry, I know it's late, but let's get two more questions.
Let's see. You can do 3, 4 questions that are there. So if you want to,
Clinically proven to help? Do you recommend it?
Repeat the question.
Any thoughts on red light therapy?
Any thoughts on red light therapy?
Is it clinically proven to help?
Is it clinically proven to help?
And do you recommend it?
And do you recommend it?
uh, I recommend low laser light therapy. Is it proven? Question mark. Some people benefit from it, probably for healing. There are a lot of things that we don't know. Is the amount of do you need 64 diodes? You need what the wavelength? When you see Capilis will tell you this, Teradome will tell you that,
Laser cap.
Laser Cap will tell you mine is. So I when there is conflict of data like that, and most of those people presenting the data have major conflict of interest because they are manufacturer, I, you know, I tend not to prescribe too much. But what I find is in female hair loss, it tend to work better, especially in telogen effluvium. So those are the only really patients that I advocate and advise them to buy uh, a laser company, uh, laser light therapy.
Yeah, and I have to say, anecdotally, I used the laser cap in my last hair transplant, and I have to say, I feel like the hair grew faster. I think there is something to say that with it getting the hair follicle into the anagen growth phase, I do think that it does stimulate growth in that way. How much will it actually make a difference? I don't know. I think the meat and potatoes is Dutasteride, if you can take it, Minoxidil, oral Minoxidil. That's the meat and potatoes. Everything else is sort of just like, it's going to make maybe a 10% difference, in my opinion.
Yeah, someone is asking about the frontalis there for the hairline. Usually, I ask patients to frown up. If you frown up, you see your last wrinkle line. You should not put your hairline in a wrinkle line. That will be one of the border that you use to not place hairline in a wrinkle line. Otherwise, every time you're going to have a facial expression, your hairline is going to be moving.
That's true. And then you're going to look like you have a hairpiece, you
Yeah,
know?
no. So that's why when looking at hairline design, I know people want the lower the best, but you have to look at these things. Otherwise, you just look like a freak.
Yeah, you don't want that. Well, let's go to the next question.
Okay. How long do you stay with your patients?
How long do you stay with
Usually
your
to
patient?
more of the patients after surgery.
Ooh,
To
so
stay
how
with
long?
them well.
So I think they mean how long do you stay with your patients during or after the surgery? Because it seems like what they're saying is most doctors tend to just, once the surgery's done, they that's it. They don't even get a courtesy call. And funny
I
story,
think I think you can ask Raphael, actually Ian, and Steve before him, and all the girls that are working in the clinic. I think we are one of the clinics that keep in touch with a patient, for a long time. I usually fly a lot to different city to do consultation. Then I do follow up of my patient when traveling, and the advisor are usually in touch with the patient for more than a year, unless the patient say, okay, guys, people want to move on also, so you don't want to be clinging to them. You have to give them space. If things are okay and they gone, but we keep in touch with the patient. It's not just like you had your transplant and bye, we don't need you. No, that's not the way we're dealing with.
After surgery.
I've been to some patients' wedding in India and all that because I kept in touch.
Yeah. I think another thing is that some patients are very anxious after surgery. So like after you're done with the surgery, what usually happens at your clinic? Do you go and check the patient, look at the make sure all the grafts are placed correctly?
Yeah,
Do you give them the
usually I
post-op?
go in and out of the surgery. I go in and out of the surgery. If it's not me, it's Dr. Costis. Dr. Costis does most of the post-op with the patient. If it's not him, is the advisor. The patient, we ask the patient to come the next day for cleaning and all that. So in the cleaning, I'll either pop up or Dr. Costis pop up. So the patients, always someone who sees them and. They know that they can, if they want to see me, they can request me. Even if I'm in surgery, I'll tell them, okay, I'm coming. So yeah.
I think one thing, and I wanted to highlight this because I think somebody came on the forum maybe a few months ago, requesting just I want Dr. Bazanga to do my entire surgery, and I think it's very important for people to understand how things work at BHR because every result that you see on on the forum, Instagram, all of that, that's all a team effort. That's not just Dr. Bazanga. I mean, Dr. Bazanga is
I
the
haven't been
leader.
placing a graph for the past 10 years. So all the result that you're seeing now is the technicians and the nurse. I have two RN nurse and the rest are technicians that have been working with me for years. And so if you request me to do your whole surgery and plant your graft, I'm not going to plant it better than someone who does it day in and day out, who've
Yeah.
been doing it for the past 20 years every day. Um, Sometime I'll pop out and place graph, or I know how to place graph, but it's just I don't place graph because I have a team that are trained and I trust them to place graph. They know what to do, and that's how we work. That's a personal choice.
Yeah, and you've been working with Costas now for a few years now, and you and him
Yeah,
are pretty much in tandem. Like you guys,
yeah.
every result that is coming out is a combination of both you and Dr. Costas. It's not just you, and I think that's one thing that people should probably realize when they're looking at your body of work. It's a team effort. It's not just um, you know Dr.
Doctor
Bazanga doing everything.
Doctor Costis is very thorough. He's been punching most of the cases because I trust him to do that because I've trained him. He spent the most time next to me and he knows how I can be anal about things. So, and so he's reproducing the way I want punching to be done.
Mm.
And even when we look together at the pictures and say, listen, this, I don't want to see soldiers in a row when you punch. And so at the beginning, it could be frustrating for him, but he has learned because he has understood exactly how to perform a good hair transplant and how to do donor management to the highest standard. So that's why I personally think that we working better when he's punching. I'm doing the site. I can punch, it's not a problem, but he's doing most of the punching. I'm doing the site. That's how we want to work because FUE is a killing machine. You break your neck, you break your back, you break your hand. I have uh, carpal tunnel syndrome. I have tennis elbow syndrome, so I have to preserve myself. The Those are the reason really when I do surgery. I like to do the site, and Dr. Costis do the punching.
Yeah, I think that's such a labor intensive procedure, FUE. If you think about extracting individual follicles thousands of times and then also creating individual holes thousands of times, also placing those grafts in these thousands of holes, within a uh uh at least a 12-hour window. How long you have to also think as a patient, how long are you really going to be in one spot? How comfortable do you want to be in one spot? If you have one doctor doing it all, you're talking about, it's 16, 17 hours you're going to be in one spot. It's not realistic, it's not
It's a
feasible.
labor intensive, and the people need to understand. People, if you want me to stay in the business for long, I need to preserve myself, and so that's how we want to work. It may not be suitable for everybody, but that's how we've chosen to do, and we're not shortchanging the patient because things are done properly, and the results are there to speak for themselves. Uh, Now it's a matter of choice. Some people may love our results, some may not love our result, but it's a matter, not everybody likes the same thing anyway. So we're not
Yeah.
offended by that. But we minimizing time outside the body. We don't manipulate the graph without care. The placing is done properly. So we do all these things to make sure that we deliver the result, because that's the reason why the patients come to us. And we value them, we respect them, and if we feel like we're not gonna give you the result, we will cancel your surgery with no problem at all. So there's no, Costis can see how many times we cancel the patient the day of the surgery just because we feel like either the patient doesn't understand exactly, or the donor is not good because they have some condition on the scalp. But we usually assess, go above and beyond to make sure that when you are in a chair, we make sure that you get the best treatment and the best care possible.
Yeah, I think that's super important, and I wanted to highlight this just because I think a lot of people have a misconception of, like, they think Dr. Bazanga, oh, okay, so I want to have surgery with just Dr. Bazanga, but they don't realize that the results that they're seeing are a combination. It's basically like, well, like you mentioned, you're doing the slits, Dr. Costas is doing the extractions, then your nurses are doing the placement. It's a team effort. It's not just one
Yeah,
surgeon.
I have a friend of mine, Lars Heitman, was the first one who was doing surgery by himself, but he does 2 days or 3 days per week surgery because he cannot do by himself everything every day from Monday to Friday. Then yes,
Impossible.
if you want to get a surgery with him, you may wait 5 years. So
Hmm.
it's also a choice on how you want to run things. Uh, um, Surgery always been something that is always multidisciplinary. If you go to an OR when they do heart surgery, you have a team. So surgery is always about the team. And I can understand some may want to go to a doctor, want to do everything for themselves, but then you have to catch them when they're not tired.
Yeah, I mean, there's a few doctors, and that's you brought up a good point. Dr. Heitman in Switzerland. There's Dr. Konier. I think Zarev. There's a few doctors that want to do everything themselves, and I think that's gotten a lot of patients wanting that. But then you have to also look at, yeah, these doctors do have a long wait list. To get a consultation might take you 2 years. To get surgery, maybe 4 years. You know, uh, there's pros and cons to everything. I think as long as you're doing things the proper way, uh, it shouldn't it shouldn't really matter. If you should be looking at the clinic's track results, their track record, the reviews, the results they're putting out. Do they have high def pictures? Do they have comb through videos? If everything is hitting that checklist, then the rest, it shouldn't really matter, in my opinion. Um,
People are asking to talk about crown work. I think that will be, maybe we'll conclude
yeah,
with that.
let's close out
So
on that crown work.
crown, what people need to understand when reconstructing crown is different than the top of your head. On the top of your head, layer of hair will lay on top of each other like a shingling roofing and give you that shingling effect and give you more coverage. In a crown, hair grow outside like on a bicycle spoke, and so you need a lot of more graft in a crown for you not to see the scalp. So you may end up putting 4 or 5 thousand grafts in a crown, but when you have a limited donor and a young patient, is it really safe to commit such a big amount of hair in a crown, knowing that this patient is going to continue losing his hair and his donor may not be sufficient? So that's why, okay, when you see crown work, you don't see wow crown work. You can add, but I'll explain. If you know 6, 7, you may have, if depend on the size of the head, but if you have a big head, you can be at 300 square centimeter to 200 square centimeter. It may take you 14, 15,000 grafts for you to get full coverage, including the crown. I mean, you're committing 4 or 5 thousand grafts in a crown for you to have a good density. So it's a matter of really how much you can afford, how much your donor can give, and what your future loss and all that. So, and if you're taking medication or not, because if you're not taking medication, then you may drop your crown later and then end up with an island of hair sitting on top and nothing connected to it.
Mm.
People who had surgery in the past will tell you, when I see patients that had surgery with me 20 years ago, and so it humble you because you see how they have become versus how they used to look. They used to look very good, and now 20 years later, they not look that good anymore. So it kind of forge your thought process and how you handle and look at the graph and the whole hair transplant. I may have a different outlook than someone who just started, who's aggressive, who want to do more, but doesn't have that 20 years time lapse to compare the patient that they have done 20 years ago.
Mm. Yeah, the crown is always such an intricate piece because I feel like, and for anybody out there watching, this is why medication is so important, right? You don't want to get to that point where you've lost crown. If you're noticing, usually you notice your hairline going first, your crown is usually last. If you're noticing that, get on medication ASAP because once you've lost the crown, it's honestly a bit of an uphill battle. It's getting the crown to a point where you're satisfied with it is very difficult. It takes a lot of grafts, and it's just something that you have to accept is never going to be perfect, especially if you're like a Norwood 6, Norwood 7. But Dr. Bisanga, thank you so much for joining me. I know it's been like an hour and a half now. Just for anyone out there who wants to talk to Dr. Bisanga, consult with them, you can reach him at info@bhrclinic.com. On Instagram, he's Bisanga hair restoration, right?
Restoration.
At Bazanga Hair Restoration. On YouTube, he's got an excellent YouTube channel, BHR Clinic. Definitely go and subscribe. A lot of good info, a lot of good content. We plan to make these podcasts a regular thing. He's one of my favorite guests, I have to say. Very insightful, a lot of good information. I mean, we could talk about hair all day. But thank you guys for joining us. I hope everybody in the U.S. out there has a safe 4th of July and spend time with your loved ones. And Chris, will you be doing any consultations in the U.S. coming up anytime soon?
Yeah, on the 29th of July, I will have consultation in Maryland.
29th of July, consultations in Maryland. So all you guys out there in the East Coast or even the West Coast, if you
I'll
want to
see
get
if I open one date in LA. I'll see, but I need to see with my wife if she's gonna allow me to travel again. That's far.
Oh man, if you come to LA, let's do a big let's do something big. I think so many people would, even if you're not planning on getting a hair transplant anytime soon, it's good to just have a consultation and just to know, peace of mind. Let me check out what my donor looks like. Let me find out how many grafts I actually need. Nobody better, I think, than Dr. Bazanga. He's gonna give it to you straight. He's not gonna sugarcoat it. And I think that's a very European thing. I know a lot of American doctors are more like they don't want to say, but look, you can't get your feelings hurt because honestly, it's going to be the truth and you need to hear the truth. Sometimes people just need to hear the truth. What's the situation? Either you're not a candidate and that's very hard to hear, but it's better to know than to get surgery and be disappointed.
Exactly. The truth will set you free.
Absolutely. All right, Chris. Well, thank you so
All right.
much. Thank you
Thank you.
guys for joining us. Till next time.
Okay. Bye.